So we have discussed last time regarding hypertension module 1. This was a hypertension specialist training program which I have given a few months back. So last time we have discussed regarding the essential hypertension, the definition, what precautions we should take in measuring hypertension, because sometimes we have got a fallacious uh, uh, diagnosis, because if we use a smaller size curve, what are the precautions one should take when we are measuring the blood pressure? The person should be sitting, calmly, or lying down in a bed with a hand at the level of the heart. The cuff size should be adequate. If the person is obese, we should have a larger cuff size. If the younger person or pediatric people are there, we should have a smaller cuff size. Then patient should not have smoked or taken tea or coffee. The bladder should be empty. Person in a relaxed position. And ideally, we should take 3 readings 2 to 5 minutes apart, and we should average the last 2 readings. That will be ideal for diagnosis of hypertension. And the different guidelines are there. They have leveled it as a high normal, but the different guidelines with the European Society guidelines and Indian Society Hypertension guidelines, they say that whenever the blood pressure for adult people 18 years and more up to 65 years, if it is more than 140/90, we need to start with pharmacological therapy. From 130 to 140 or 85 to 90, we can have lifestyle modifications. And sometimes we have got white coat hypertension, whose blood pressures are high in the clinic, but the home blood pressure are normal. And sometimes we have got masked hypertension. In masked hypertension, the blood pressures are normal in the clinic, but during their working hours, because most of them, these are having, very high sympathetic output during their working hours, or in their office, out of office, doctor's office setting, their blood pressures on a higher side. It is called as masked hypertension. But they come to you, when they come to the doctor's clinic, their blood pressure is on a normal range. When they go out and their own working environment, their blood pressures are on a higher side. That is called a masked hypertension. And there are two modalities now which we very commonly use in our clinical practice. One is home blood pressure monitoring methodology. Another is ambulatory blood pressure monitoring. And now these two are very important tools for diagnosis of white coat hypertension, for diagnosis of masked hypertension, and even for monitoring of, like, somebody who comes to this. We have seen very commonly in our practice, even at Mahamana also, that people, those who are coming for chemotherapy on the day of hospital visit, they are in a great stress. Their sympathetic activities are high. They have not taken their blood pressure medication on that day, because many of them, they say that I have not taken any breakfast or anything in the morning. So people have got a myth that they have to take their medication after eating something. So that's not the case. And I have discussed on the last discussion day that the ideal time for giving an antihypertensive medication is an evening hour. So we should have early morning surge should be covered up. And people, those who have got a high blood pressure of stage 2 or stage 1, particularly stage 2, people require single pill combination of two group of drugs, that is ACE inhibitor ARBs or calcium channel blocker. They are the preferred choice, or ACE inhibitor ARB with diuretic, or calcium channel blocker with diuretic. Beta blockers are not indicated as a first line drug for management of hypertension. People with a severe form of hypertension, we can have a triple drug combination, which consists of ACE inhibitor ARB, calcium channel blocker, and a diuretic, which is usually we use thiazide like diuretic. And thiazide like diuretics are chlorthalidone, chlorthiazide, and indapamide. Indapamide, though, has got a vasodilatory effect also, and it is a quite good antihypertensive drug, but it usually takes, the vasodilatory effect takes usually 2 3 weeks to come down. And these diuretics, whenever they are in a long-term chronic use, we need to monitor the patient's electrolyte levels, and we need to, and particularly in elderly people, we need to look after for their uric acid level, as well as their triglyceride level. Because it has been observed that in the long-term use of diuretic therapy, hyperuricemia, hypertriglyceridemia, and glucose intolerance is a common complications. So if somebody is diabetic, using a thiazide-like diuretic is not a contraindication. We can use that, but we have to keep a watch over their uric acid and triglyceride level. If they are high, they needs to be corrected with the uric acid lowering drugs, as well as the triglyceride lowering statins with fenofibrate. So now coming to today's, this was just recapitulation of the previous module which was discussed. Now today we are going to have a discussion on secondary forms of hypertension and iatrogenic causes of hypertension, and we have got a hypertension in young, old, and other variety of how to proceed in those patients. So what is secondary hypertension? As we have discussed on that day, that if you look into, this is a European Society guidelines which was published in 2018, that if you look into a whole bunch of hypertensive patients, out of those 5% of people are having a secondary form of hypertension. So around 95%, they don't have a secondary form. They are usually essential hypertension, or what we call as a primary hypertension, where the exact pathophysiology is not known, but the mechanism belongs to a vasoconstriction and increased sympathetic activity. Around 30%, 25 to 30% of people, they have got a resistant hypertension. When should we call a resistant hypertension? When we have already used 3 group of drugs, out of which one should be an ACE inhibitor ARB, the other should be a calcium channel blocker, and third should be a thiazide-like diuretic on a maximum tolerable dose with a good and best patient compliance. The patient should have taken their medicine regularly. Their blood pressure are not in a target control of less than 140/90. It should be confirmed many times with ambulatory blood pressure monitoring as well. Then we can level them a resistant hypertension. And one of the common cause of resistant hypertension is hyperaldosteronism, and we need to give them a lectone group of drugs or mineralocorticoid receptor antagonists for those group of patients. So this was the level of secondary hypertension, that we hardly get 5% of people those who are having secondary hypertension. And what are the general clinical characteristics which suggest you that this patient belongs to not an essential hypertension category? The first and foremost is that early onset of hypertension, because when you see young hypertensive patients less than 30 years without other risk factors like family history, obesity, then you should have a suspicion of index of suspicion very high that this person can have a secondary form of hypertension. And out of all secondary form of hypertension, the causes of renal etiology, or the renal parenchymal disease or the renal vascular hypertension, are one of the important causes. And then the next one is an endocrine causes. So resistant hypertension, despite of 3 antihypertensive drug therapy, including a diuretic, and whenever you are assessing your own antihypertensive therapy, you should always look into whether the patient has been prescribed a diuretic or not. Because if you from this lecture onward, you keep on seeing different variety of prescriptions from different physicians and colleagues, you will find that many of them, they are missing diuretic therapy as a third antihypertensive drug. But until unless you have got a third antihypertensive drug as a diuretic, you cannot say that blood pressure is not a good control and the patient is having a resistant hypertension. The other clues which will give you a point of suspicion that the patient might have a secondary hypertension is severe form of hypertension, like blood pressure is more than 180/110, or patient is having hypertensive emergencies. Sudden increase in BP in a previously stable patient. This is very commonly seen with pheochromocytomas and all. Non-dipping or reverse dipping during the 24-hour ambulatory BP monitoring. What is non-dipping? Usually the blood pressure drops by more than 10 millimeters of mercury in the night hours when the patient goes for sleep. But if this dipping phenomenon, this is a normal phenomenon for each and every person, and even for hypertensive people as well. But if you find that their ambulatory BP shows there's not a drop in the blood pressure, but there's a rise in blood pressure that is called as reverse dipping during the 24-hour ambulatory monitoring. You should suspect a person can have a resistant hypertension. And the presence of target organ damage, like suppose somebody who is diagnosed to have a hypertension, blood pressure, he has come to you in your OPD and you have seen that his blood pressure is around 160, 100, 110, and you got a just single target organ damage tool in your hand like a ECG. And you can see a classical ECG change of left ventricular hypertrophy that S in V1 and R in V5 is more than 35, or there is a systolic strain pattern, or a left axis deviation, or a left atrial enlargement, or those things which I have discussed with some of you in your ECG class. That if those changes are there, and or patient can have, if you've got a small tool in your hand of looking into the patient's fundus examination, or if you've got a urine routine examination, there's the proteinuria and the urine. These all suggest that patient has got a target organ involvement. And if the patient has got a target organ involvement, either in the form of retinopathy, hypertensive retinopathy, or in the form of left ventricular hypertrophy, or proteinuria, then you can think of that this patient can have a secondary hypertension or a very severe variety of hypertension. So how to work up with these patients who have suspected secondary hypertension? Like I have discussed on that day also, or probably if I have not discussed, then this is a usual routine that whenever we are looking for any patient who is a hypertensive, what routine examination we have to do on a physical examination as well as the routine investigation. The routine investigation in any hypertensive patient requires their sugar assessment, requires their lipid assessment, requires their uric acid assessment, requires their kidney function assessment, urine, looking for urine cast, urine crystals, proteinuria, ECG examination. Suppose if you don't go for a echo examination, because echo sometimes is a costly investigation. And I want to add here to all of you that many times we in a Mahamana keeps on using this terminology of 2D echo, which is wrong and which is fallacious, because 2D echo is one modality of echo test. Now the echocardiography consists of any basic echocardiographic examination consists of a 2D echocardiography as well as the Doppler and a color Doppler. So whenever you are saying that a person requires an echocardiogram, it is ideal, usually ideal to say transthoracic echocardiographic examination or TTE, or if you require to see a transesophageal echocardiography, which is an invasive echocardiography, then you can say TEE. Doing a transthoracic echocardiography means doing a M mode echocardiography, doing a 2D echocardiography, doing a Doppler assessment of the person, doing a color Doppler and a tissue Doppler. So now an echocardiography doesn't mean only 2D echocardiography. The echocardiography nowadays is like, like if I will say that you are active member of social media, and social media doesn't mean only WhatsApp. It also means many more, Twitter and Facebook and all those things. So suppose somebody says that he is the only active member of WhatsApp or social media, doesn't completely continues to what is exactly saying for. So looking for an echocardiography, which should be 2D, M mode, Doppler, color Doppler, and tissue Doppler. These are all different modalities of echocardiography. It has to be done for a patient who is having definitely grade 2 or grade 3 hypertension, just to look into the target organ damage, just to look into the hemodynamics of the patient, as well as chest X-ray is very important, because sometimes you get a clue of coarctation of aorta as a rib notching in patients of secondary forms of hypertension. Fundus examination. So fundus examination, routine biochemistry, routine hematology. We should look for anemia, because anemia is a very common important factor in patients with chronic kidney disease with hypertension. So anybody who has got anemia, with proteinuria, hypertension, you should always suspect for having a secondary form of hypertension of renal origin. So out of that, whenever you are examining a patient in a clinical practice, the age of the patient, the habitus of the patient, whether the patient is having a resistant or a severe type of hypertension and target organ damage. I have discussed regarding what are the points regarding target organ damage. The next point, which is very, very important for assessment of 24-hour ambulatory BP, is exclude for white coat hypertension. And how you can do that? Until unless you do a 24-hour ambulatory BP, you are unable to assess it. And many of us are not very much exposed to 24-hour ambulatory BP monitoring, but it is a very simple tool you all can use in your clinical practice. It is a, you can say, a smart way of assessing your blood pressure for your patient, and it is just like a halter machine which you all must have heard of. That the blood pressure curve is tied with your arm, and it is programmed for taking a blood pressure every 1 hour in the daytime and 2 hours in the night time, and you should instruct the patient to make their hands at the level of the heart when the when the machine is taking the blood pressure. It is basically like a automatic blood pressure machine, which all of you must have used in your clinical practice. So white coat hypertension is usually seen in an anxious patient, those who got increased sympathetic activity, and it has been observed in a clinical practice that people, those who are having white coat hypertension, means their blood pressure is raised in the clinic, and it is blood pressure is normal at their home atmosphere or in their out of hospital setting. And it has been observed that around 10 to 15% of these white coat hypertensive people, they actually turn off into an hypertensive patient future in the course. There is one other terminology called as white coat effect. What is the difference between white coat hypertension and white coat effect? White coat hypertensive people are not really diagnosed as a patient of hypertension. They are usually a white coat hypertensive people. We can keep a watch on them, and we can have a lifestyle modification and mind body meditation and mindfulness techniques and yoga and savasana in these group of patients to keep their sympathetic level on the lower side. But the white coat effect are people who are diagnosed hypertensive. When they come to your clinic, their blood pressure rises in spite of their blood pressure antihypertensive effect as well. So white coat effect is an effect of a rise in blood pressure in your clinic when the patient who is diagnosed already hypertensive comes to your clinic, and because of this increased sympathetic activity and anxiousness and all those factors. And we should always rule out pseudo resistance. And what is pseudo resistance? I have discussed with all of you in a previous module that if you are using a smaller size cup in a thicker arm, this is called as a patient can have a higher blood pressure recording. If you use a larger size cup as a thin built patient, then it will record a lower blood pressure in your blood pressure recording. So if the smaller size cuff has been used, or the patient is not consuming the antihypertensive medication properly, and he malingers that I'm taking antihypertensive medication, these may be, you might be thinking of the patient is already on 3 antihypertensive drugs, out of which one is a diuretic. So that suggests that probably it's a pseudo resistance. And dipping status and heart rate, because dipping status, the patient is a non-dipper, then we can think of going to a secondary form of hypertension. And exclude other factors like exclude drug-related hypertension, a very important point. Like we have seen in our clinical practice with I will tell you one example that one of my patients who is a hypertensive stage 2 patient on ACE inhibitor and calcium channel blocker, following very well, and his blood pressures are very well controlled, less than 140/90. One fine day he came in the emergency with severe headache and blurring of vision and all those, and he recorded his blood pressure was 190, 200/110, and so I was really surprised. I asked him whether he has regular medication. He said yes, I'm taking my regular medication. Then I said, did you have any other medication also with you? He said yes, I had some back pain, and there was severe back pain, so I went to an orthopedician. He prescribed me this medication. He showed me the prescription. The medication consists of eterocoxib, and the other time the medication prescribed by a dentist, it was Zerodol P, that acylophenate with paracetamol. So, and third time I have seen one patient who was prescribed for prednisolone for the short-term course for 2-3 weeks for his facial paralysis. So all this prednisolone, NSAIDs, and COX-2 inhibitors, they are detrimental and they causes rise in blood pressure, and these are called as drug-related hypertension, which usually people develop. We immediately stopped his heterocoxib and stepped up his blood pressure antihypertensive drug therapy. We have keep him in observation for 24 hours, and things become settled down, and he was discharged. So always take a note of other medications history when the patient has the blood pressure was previously controlled becomes suddenly uncontrolled, and always confirm therapy with adherence. Like I have seen many times in my practice, patient blood pressure was very well controlled. He was on 3-drug therapy, like a very common combination comes in the market with telmisartan, amlodipine, and hydrochlorothiazide by different pharmacological companies. And he came to us. The patient was very well controlled on 80 milligram of telmisartan, 5 milligram of amlodipine, and 12.5 milligram of hydrochlorothiazide. So he was a very severe variety of hypertensive. And he came to us on a OPD. And his blood pressure was again 160 by 100. I asked him whether you had taken your blood pressure medication or not. He said, yes, in the morning, because I was starting from Azamgarh, or I was starting from Sasaram. So I have taken nothing. And I started early in the morning, 4 o'clock. So I thought when I will eat something, so I will take my antihypertensive medication. So in morning, I have forgot to take my medication. Just now, around a half an hour before, I have taken some breakfast and then I took my medication. Or he said that no, today I have not taken my medication. I was thinking that let's see what my blood pressure will be if I will not take a blood pressure medicine today. So these type of experiments are usually done by the patient. So be always careful with them. And this type of modifications are usually seen, and we should rule out before leveling them as a secondary hypertension. And what are the other causes of secondary hypertension, which are very, very common in our clinical practice? Snoring and obstructive sleep apnea. All snorers are not having OSA, but obese people with a short neck, with a history of snoring, with a daytime somnolence, they are usually having an obstructive sleep apnea, which is a very common problem in alcoholic, obese people, diabetics, hypothyroid, and we need to rule it out and do a sleep study in them and advise them to have a CPAP therapy. And I have personally seen that 2 or 3 of my OSA patients who started regularly using CPAP therapy, their antihypertensive medication doses have been reduced, and one of them has been off antihypertensive medication just because of proper management of obstructive sleep apnea. So it is very well widely available in the city, the sleep study, and now even people, the company people, they used to do it in the home setting as well. And we used to monitor the patient's EEG, patient SpO2, patient's pulse, and patient's blood pressure, and rapid eye movements or eye movements during the 24-hour during the sleeping time in the sleep study. Now, the renal parenchymal or renal vascular disease, primary hyperaldosteronism, and other endocrine causes. And the other important is aortic coarctation. So whenever you are looking for a younger people and there's a severe form of hypertension, and suppose she is female as well, always look for all pulses. One of my professors in cardiology, he used to teach us that whenever you are examining a patient first time, you always examine all his peripheral pulses. Suppose you are examining pulse, start from carotids and carotids and radial, brachial, and femoral and popliteal. Suppose the patient is bearing close, you can very well easily see the popliteal pulses and dorsalis PDs. Sorry, not popliteal, dorsalis PDs. You can very well see with just asking the patient to lie down and examine all 4 pulses. For any hypertensive patient is must, because even we were deceived once or twice if we were not taking all the peripheral pulses. The coarctation of aorta in a severe hypertension and secondary form is a very, very important thing. And just a clinical examination will give you a clue. There's an radiofemoral delay, or there's a blood pressure in the femoral pulses, and the dorsalis PDs are feeble compared to the radial. And the other important that whenever you're examining a patient for the first time as a hypertensive patient and you want to start an antihypertensive therapy, you're making a diagnosis of hypertension. Always, always, always examine the blood pressure in both the arms, because even I, being a very attentive physician, I have realized that in a busy OPD, whenever I have made a diagnosis of hypertension and labeled the person as a hypertensive, because it happens many times you're sitting in your OPD in a particular posture, your patient's stool or the patient chair is towards your right side. He always offers his left hand to measure it, and we are measuring most of the time in his left hand. Whenever he comes to you in OPD, you are measuring in the left hand, you're not measuring in the right hand. But you first time when you are labeling him as a hypertensive patient, always see in both the arms. I have committed a mistake of not diagnosing a person of Takayasu arthritis, because the Takayasu arthritis is a common clinical problem in young females. They usually have a history of severe hypertension. There's difference in the arm blood pressure because there is subclavian arthritis. They usually have a carotid bruit and vision disturbances and seizure disorder. There were a difference in their upper limb and lower limb pulses as well. But the upper limb pulses of both the arms are very, very important. So that's the importance of a clinical examination. And secondary causes of hypertension are the important ones I'm mentioning here. Obstructive sleep apnea, I have already discussed with you. Renal parenchymal disease, you can very well rule it out by looking for the ultrasound, looking for the hemoglobin level, looking for the for the urine routine microscopy. And if the ultrasound shows, chronically shrinked kidney or scarring in the kidney. And I also remember that, renal stone disease is also one of the important cause of hypertension. And I remember a person in mid of my practice around 20 years before, a person was diagnosed with severe hypertension by one of the cardiology colleagues, and he came to me. The part of my routine practice I used to do that, those who are very severe hypertension, I get them ultrasound examination. I asked him whether any time you have been prescribed for ultrasound of your kidneys. He says no. I said, okay, then it's fine to get a ultrasound. It's a cheap investigation, some 300, 400, 500 rupees. He went for the ultrasound and came back to me that there's a stag horn calculus in the one of his kidneys. And later on, one of my urology colleague has operated upon him and removed his stag horn calculus, and his blood pressure from stage 3 hypertension has become a very mild hypertension. Later, that patient is still with me in a follow-up for last 15 years or so now. We implanted a pacemaker to him for some other reason. He has got an angioplasty. But the problem of his severe hypertension, which was diagnosed to have a secondary or severe hypertension, was improved. Renal artery stenosis. Renal artery stenosis are commonly seen either in the younger individuals, the young females with renal vascular dysplasia or renal vessels involvement are common phenomena. Or you can find in elderly people with diabetes, with other severe peripheral vascular disease, or you can have a Takayasu arthritis in a young female. So these all three will lead to a renal artery stenosis. Primary aldosteronism is one of the important cause which has been noted. Cushing syndrome, whenever see a Cushing-Guard obesity, stria over the back, stria over the abdomen with diabetes and hypertension. When once upon a time I also diagnosed in my practice, just because patient was under treatment as a diabetes and hypertension, and nobody has taken time to open up the patient's back and open up the patient's neck to see there was a lot of stria over the neck and the back, and we got the serum cortisol level, and that's it's done. Acromegaly, then thyroid disorders. Thyroid disorders are very common. Hypothyroidism, one of the important reasons for hypertension. Pheochromocytoma, where we get very high levels of. They usually have a palpitation and sudden rise of blood pressure going up to 120, 200 and above. Patient usually present with hypertensive emergencies. Hyperparathyroidism, coarctation of aorta, and BP raising medication and drugs, which I have already enumerated. NSAIDs, COX-2 inhibitors, steroids, literacy, and many more drugs, so on and so forth. So features of secondary hypertension, like if you're looking for a renal parenchymal disease, which we commonly see in a clinical practice of our patients, those who are having CKD, what findings you will have? There is a proteinuria, hematuria, leukocyturia on dipstick urine analysis, decreased GFR, and kidney ultrasound will give you the clue and definite diagnosis. For primary aldosteronism, symptoms of hypokalemia. If you find low potassium levels in your routine clinical biochemical test, which will give you a clue that probably the patient might have a primary hyperaldosteronism, muscle weakness, muscle cramps, and tetany. The basic biochemistry is spontaneous hypokalemia, means hypokalemia usually are seen as a when the patient is not on diuretic therapy, but even so few of them they have a even on diuretic therapy, uh, which was very pronounced hypokalemia, and on blood biochemistry, around 50 to 60% of patients are normokalemic. Elevated plasma aldosterone renin activity ratio. So you have to look for plasma aldosterone renin activity, and that may be high. Confirmatory testings are intravenous saline suppression test and imaging of adrenals. Imaging of adrenals and a CT abdomen is one of the very important investigative tool for primary hyperaldosteronism, and adrenal vein sampling nobody does nowadays. Renal artery stenosis, you all know very well. There's abdominal bruise in the clinical examination, bruise over other arteries like carotid and femoral, drop in estimated GFR more than 30% after exposure to ACE inhibitor or ARBs, or for suspected atherosclerotic, whenever the patient is having severe forms of atherosclerosis, elderly patient with diabetes and other problems, you can suspect to have atherosclerotic renal artery stenosis, and history of flash pulmonary edema. History of flash pulmonary edema is very important, or history of atherosclerotic disease or presence of cardiovascular other risk factors like diabetes, dyslipidemia, smoking, tobacco. Fibromuscular dysplasia, as I've already said, that is commonly seen in younger women with new onset. So renal artery stenosis, if you are suspecting, it should be either in the younger women with the fibromuscular dysplasia of renal arteries, or in the elderly people with a plenty of other atherosclerotic risk factors. And how you can diagnose? Doing a ultrasound, duplex ultrasound imaging of renal artery, which is very commonly done by our radiologist colleague. But don't ask on a routine renal Doppler studies for all secondary hypertension patients, because somebody comes to you with a 40-year-old male having less, like if the person is a young female with a severe form of hypertension, always suspect to rule out fibromuscular dysplasia and renal artery stenosis. And it can be confirmed over by computed tomography or MRI angiograms on the ability of the patients. Then pheochromocytoma is very important. We have seen 2, 3 recently in last 2 years or so. And my endocrinologist, endocrine surgeon colleague has operated upon those 2 young ladies, and they very well improved. The history was, like headache, palpitation, perspiration, pallor, and labile like of hypertension. And few of them, was diagnosed by a psychologist or a neurophysician as a hysterical female, or diagnosed as a patient is a malingering or something like that. But when we found the patient is having severe headache with palpitation, her blood pressure was 200 by 110. We did her basic biochemistry and urine analysis. There's an increased plasma level of metanephrines, increased 24-hour urinary fractional excretion of metanephrines and catecholamines, and usually the diagnostic for the tests were done by abdominal or pelvic, CT or MRI. Cushing syndrome, central obesity, purple stria, facial rubor, signs of skin atrophy, easy bruising, dorsal and supraclavicular fat of pad, and proximal muscle weakness. You all must have seen a Cushing's diagram in your clinical practice or in your Davidson textbook of medicine. And the common biochemical findings are hypokalemia and increased late night salivary cortisol. The important investigation for a Cushing syndrome is dexamethasone suppression test. Overnight dexamethasone suppression test, where people are given dexamethasone in the night, and early morning plasma cortisol, fasting plasma cortisol was taken. Usually dexamethasone causes suppression of endogenous release of plasma cortisol, but suppose it is not suppressed, it is still raised, we can suspect of getting a Cushing syndrome. And 24-hour urinary free cortisol, which is a difficult task. Abdominal and pituitary imagings are usually done to look for Cushing syndrome etiology. Coarctation of aorta, high blood pressure in the upper limb and lower than the lower extremity, delayed and absent femoral pulses. Echo is one of the most important diagnosis, and you will look for abdominal aortic flow and some suprasternal echo roots. We can like to see that what is the aortic arch flow. Computational tomography angiograms or even many times doing MR angio is one of the important tools. Obstructive sleep apnea, where you can have suspicion, increased BMI, snoring, daytime sleepiness, gasping or choking at night, and witnessed apnea during sleep, and nocturia. And the most important test is doing a home sleep apnea testing, or you can do a overnight polysomnography testing. That's called a the sleep study on a common man's language, and which we do in a dedicated sleep lab. And we have got now very good chest physicians in our city, and I'm very happy to say that they do a very dedicated sleep studies, and people are prescribed for CPAP therapy. And it's not a very costly affair, and normally haptic. And but doing a CPAP sleep study is one of the most important part of assessing to them. And thyroid disease is a very common clinical problem. Symptoms of hyperthyroidism, we all know: heat intolerance, weight loss, tremor, palpitation, and symptoms of hypothyroidism: cold intolerance, weight gain, dry and brittle hairs. And it is easy to look for thyroid levels of TSH, 3 T4, and all those things. I just want to add one more important point, because thyroid is very commonly done test, and many of our colleagues, they start thyroid supplementation on a TSH level, diagnosing them to be a primary hypothyroidism on a TSH level less than 10. But usually TSH level less than 10 and between 5 to 10 is called a subclinical hypothyroidism. And subclinical hypothyroidism, there are definite indications to start thyroid supplementation therapy. Is either a patient is having sexual dysfunction, or the patient is having mood depression, or the patient is pregnant or something like that. Otherwise, it is always better to get their anti-TPO done and watch for their thyroid profile another 3 to 6 weeks. So management of secondary hypertension is comprised adequate control of blood pressure with antihypertensive drugs and addressing the secondary causes, and refer to a specialist center with access to appropriate expertise and resources. Like suppose you suspect any secondary cause of hypertension, you should refer to a specialist center who can do 24-hour ambulatory BP, who can look for their duplex ultrasound, sleep study, and they look for patient plasma cortisol level and metanephrine levels and all those things. Iatrogenic causes of hypertension, I've already discussed with you, and how to suspect or correct the drug interaction. There are multifactorial conditions with the common side effects exerted by drugs that are indicated for unrelated medical conditions, and iatrogenic hypertension can be aggravated further by drug interactions. So it is always important, whenever you are prescribing any drug to your patient, look for what medications a patient is taking, and other medications has to be recorded. And there's a list of other medications, like one is oral contraceptive pills, particularly for especially estrogen containing pills may cause hypertension. Diet pills, for example, the phenylpropylamine and sibutramine, which is now no more used in clinical practice. Nasal decongestant, like many of the patients are using Otrivin, like nasal decongestant of phenylephrine hydrochloride and naproxen hydrochloride. These are very important to cause a drug-induced or iatrogenic-induced rise in blood pressure. Stimulant drugs like amphetamines, cocaine, and all those things. Literacy, that chronic excessive literacy use mimics the hyperaldosteronism by stimulating the mineralocorticoid receptors inhibiting the cortical metabolism. Immunosuppressive medication. This is very important for people those who are on immunosuppressive like cyclosporin A, steroids, corticosteroid, and hydrocortisone. Anti-angiogenic cancer therapies. These are very commonly used by many of our medical oncology people, and they during the chemotherapy drugs schedule. I will like Dr. Akhil to enumerate them, but there are few like bevacizumab, that is VEGF inhibitor, and tyrosine kinase inhibitors like sunitinib and sorafenib have been reported to increase the blood pressure. So I think when a person is on oral anti-cancer drugs and on these anti-cancer drugs, they should have a mention. You all are better well versed with that, which are the drugs which causes rise in blood pressure. So we have to take care of them, and in particularly in hypertensive patients. Other drugs like anabolic steroid, erythropoietin used in patients of CKD are non-steroidal anti-inflammatory drugs, and herbal medicines. Like whenever a person is taking Ayurvedic herbal medicine, we should always, be careful because we are never aware about that what are those Ayurvedic or herbal medications are there, whether any of them are rising, causing a rise in blood pressure or not. But hypertension in children and adolescents, I will definitely take this for a short few slides on them. The definition of hypertension in 1 to 18 years of kids. For children less than 13 years, when the normal blood pressure, whenever it calls, we will call it is less than 90th percentile, and ages more than 13 years, one normally is 120 by 80. Elevated blood pressure is when the more than 90th percentile and to 95th percentile or 120 by 80. Elevated when we call it when it is more than 120 by 80, and stage 1 hypertension is similar as 130 by 80 or between 130 to 139 and 80 to 89 hypertension for kids 1 to 13 years. Stage 2 hypertension is more than 140 by 90. So for kids, the guidelines are different, and what we were discussed last time was only for adult people. So now, are we all connected now?
Yes, sir. Yes, sir. You can restart sharing.
There are only a few slides are left, so we can just finish it within another 10 minutes or so. Is it visible to all of you?
Yes, visible, sir.
Okay. So management of high blood pressure in children and adolescents, the recommendations are the treatment goal with the non-pharmacological and pharmacological therapy should be reduction in the systolic blood pressure and diastolic blood pressure to less than 90th percentile of that age group. And in that 90th percentile usually recommended by the Pediatric Association is less than 130 by 80, millimeters in adolescent, or more than 13 years old. Diet and physical activities are important as an important tool. But now we are seeing more and more number of obese children in our country, and the hypertensive children and adolescents who have failed lifestyle modification, particularly those who have LVA hypertrophy and echocardiography and symptomatic hypertension or stage 2 hypertension without a clearly modifiable factor, that is obesity. Clinicians should initiate the pharmacological treatment with the ACE inhibitor ARB or long-acting calcium channel blocker or a thiazide diuretic. But I will always suggest that take an opinion of your pediatric colleague and take help of a specialist before embarking on treatment for a younger individuals. An assessment of effectiveness are usually done by ABPM, and definitely it's a difficult option for assessment in a kids of less than 13 years or so. And ABPM may be used to assess the treatment effectiveness in children and adolescents with hypertension. And we have commonly seen in our clinical practice, one is the coarctation, other is chronic kidney disease, and third is a Cushing's or pheochromocytoma. These are the important secondary causes of hypertension in kids, which we have seen our clinical practice. So, and hypertension in older adults that age more than 65 years or so, the factors which are responsible for elderly people having hypertension is arterial stiffness, neurohormonal and autonomic dysregulation because of decreased beta reflex sensitivity and declining renin-angiotensin aldosterone system. Aging kidneys are characterized by progressive development of glomerulosclerosis and interstitial fibrosis, which is associated with decline in GFR. And reduction of other homeostatic mechanisms are there. So elderly people are more likely to have a comorbidity such as renal impairment, the GFR is reduced, atherosclerotic vascular disease, and postural hypotension. And postural hypertension is very, very important for elderly people, which may worsen by BP lowering drugs. So whenever we are prescribing drugs for elderly people, age more than 65 years, you should always look for sitting and standing blood pressure in your clinic or your follow-up. And older patients also frequently take other medications which may negatively interact on those used for achieve blood pressure control, like they commonly take NSAIDs for their orthopedic problem, hydrocoxib for the orthopedic problem, and antihypertensive treatment substantially reduce the severe morbidity and mortality in such cases. So treating them rightly and treating them in a right way is very, very important. And BP lowering drug treatment and lifestyle interventions are recommended for fit older patients more than 65 years, but not for 80 years and above when BP is in grade 1 range. Like people those who are 80 years plus, but what we call as stage 1 hypertension of 140 to 159 or 140 to 60, we can have a less aggressive approach, or we can treat them with a less aggressive approach if the people is more than 80 years or above. And the best choice is a calcium channel blocker or a low dose diuretic. An antihypertensive treatment may also be considered in frail elderly patients if tolerated, but we have to be very, very cautious in these elderly people because whenever they are receiving BP lowering drugs, it is recommended that the BP should be targeted in the range of 130 to 140 and close monitoring of adverse effects. And the most common adverse effect in these patients are, they are postural hypertension and hypokalemia. These are the two important drugs, and hyponatremia as well, because they present with they're taking a lot of other medications, and hyponatremia and hypokalemia. These BP targets are recommended for patients at any level of severe risk and patients with and without established CVD. The diastolic blood pressure target of less than 80 should be considered independent of the level of risk and comorbidities. But what we find in the elderly people that there's a arterial stiffness, and due to the other change in the hemodynamic level, there usually diastolic blood pressure falls up to 50 or 60. So up to 60 it is fine, but it is going less than 60 up to 50. We have to be a little more careful and less aggressive in treating them. Hypertension in very elderly people, like age more than 75 years. BP is measured traditionally on the upper arm using either auscultatory method, which I have discussed with all of you, or an oscillometric method requiring the clinically validated automated blood pressure measurement machines. And out of office measurement using ABPM and home blood pressure monitoring are recommended to confirm the diagnosis of hypertension. Two major issues with hypertension are weak discriminative power of elevated BP for having or not CVD later in the life. To overcome these issues, two approaches are possible. First approach is the high CVD risk prevention strategy, and decision to treat hypertension is not based on BP level, but rather on an estimated absolute cardiovascular disease risk assessment, like assessment of diabetes, assessment of lipid levels, tobacco, and all those things. And second approach is population-based prevention strategy, shifting the distribution of BP towards the lower levels within entire population instead of lowering BP only in high risk population. But we are basically following the first approach of high risk CVD risk prevention strategy and not treating the whole of the population. And you all know that the benefit of BP lowering among the old is disputable, because while these patients are very high risk for CVD, there are doubts that a true benefit of BP lowering drugs on mortality and other health outcomes are there. But it has been seen that if their systolic blood pressure is more than 150, which is called as isolated systolic hypertension, the diastolic blood pressure is normal, but systolic is more than 150, that is called as isolated systolic hypertension. Lowering the isolated systolic hypertension also helps in CVD reduction and reduction of stroke, MI, and other things. And instead of being beneficial on low BP, might indeed be detrimental among old people. So we should not go, very low, like systolic blood pressure less than 100 or so. These people are going to suffer. Their coronary perfusion also get impaired. And the fit older patient with hypertension at age more than 80 years, BP lowering drug treatment and lifestyle interventions are recommended if the blood pressure is more than 160. And antihypertensive treatment may also be considered in frail old elderly people if they can tolerate. So a systolic blood pressure target of 130 to 140 is recommended for people more than 80 years, and diastolic for less than 80 should be considered if they can tolerate well. So resistant hypertension mechanism workup, management and follow-up, hypertensive urgencies and emergencies, clinical recognition, diagnosis, treatment, device-based interpretation such as renal denervation. These all we can take up in the next session, because resistant hypertension itself is a very common important clinical problem. So I'm not going to discuss in detail. I will just try to highlight the causes of pseudo hypertension, the poor adherence of prescribed medication, white coat effect, poor office BP measurement, clinical inertia resulting in the inadequate dosage. So I think we will take up resistant hypertension in next setting, because it's a quite important topic, and we have already finished an hour, I think so. So there are different steps of having a management of resistant hypertension. Just for the sake of reference, I can clear it out here, that the first step is to exclude the other causes of hypertension, including the secondary causes of hypertension, white coat effect, and medications of non-adherence, and ensure the low sodium intake, maximize lifestyle intervention, that more than 6 hours of uninterrupted sleep, overall dietary pattern, weight loss and exercise, and then optimize 3-drug regimen, which is already enumerated last time also, and adherence of 3 antihypertensive drugs, RAS blocker, CC, calcium channel blockers, maximize the maximal dose tolerable, and diuretic type must be, if the patient is having chronic kidney disease, even taking for a loop diuretic is also important. And in spite of all this, the step 2, BP is not at target, then substitute optimally dose hazard diuretic, clothiazide or indapamide for the prior diuretics. BP is not a target. Add melanocorticoid receptor antagonist, spironolactone or epinephrine. BP is still not target. Go for step 4. If the heart rate is less than 70, add beta blockers and or alpha beta blocker. You can give it or centrally acting drugs like clonidine or moxidine. And still the BP is not at target, add hydralazine 25 milligrams 3 times a day. Still BP at not target, and then go for minoxidil 2.5 milligrams 2 to 3 times. But these are the group of patients which usually you find in a renal hypertension patient. I will just take 2 slides for hypertensive emergency and urgency. That day I have already said that hypertensive emergency and urgencies are 2 different subsets. What is hypertensive emergency? Like you all must have, you all must have seen that the symptoms of hypertension In hypertensive emergency, the symptoms are yes, but in urgency, there is no or minimal symptom. The acute rise in blood pressure is an hypertensive emergency, it is yes. In both urgency and emergencies, acute target organ damage are seen in emergencies, like having papilledema, having brain edema, having acute LVF, but not in urgency. BP reduction rate is in hypertensive emergency, it is minutes to hours, but in urgency, you can take time, hours to days. Like one patient came to me around 2 days before, his blood pressure was 200 by 110. Some physician has seen the patient and is asked to get the patient admitted. Patient, I asked him whether do you have any eye discomfort, any chest pain, any shortness of breath, any such symptoms of these symptoms of emergency. He said no. I said then no need of getting admitted. Get yourself investigated thoroughly for all secondary causes. I have prescribed him 3-drug combination of telmisartan, amlodipine, and chlorthalidone. And next day afternoon, when he met with all his blood investigation and ultrasound and echo and ECG, most of things were normal, except that he has got some amount of hypertriglyceridemia and dyslipidemia. Renal functions were normal. Echo was showing LVH. So I continued his 3-drug, and his next day's blood pressure was 140 by 90. So these patients doesn't require admission. So it's called as hypertensive urgency. But because we need to control it within hours to do, then I explained the risk of having severe hypertension to him. I said it is very, very important for you to take care of. And then just I also mentioned yesterday's example. That yesterday when I was going out of my office, a patient came from outside with somebody's reference. That patient is having severe hypertension and having severe headache for 2 days. One of my junior colleagues, he has seen the patient and he is advised for all investigation. And when he came to me after the investigation, I saw that there was no proteinuria, but the ECG showed severe LVH and STT changes. Echo showed LVH. Patient is still complaining of headache, no neurological deficit. I said, you go and get your CT brain done before you leave the hospital. And he was very much adamant that how can you see the CT now? You're going out. I said, go and get your CT done and report to the emergency room. They will connect it to me. And to your surprise, when the patient has got his CT done and reported to emergency room, it was subarachnoid hemorrhage. Patient was admitted in the neurosurgery department with severe blood pressure. We have already started the antihypertensive medication on them, but the subarachnoid hemorrhage was a real important cause of hypertension. So these are the other examples which we see in our clinical practice. And evolution for secondary hypertension is very, very important, and we need to do in all these two groups of patients. Those who are coming to you as an hypertensive emergency and urgency, you need to know the secondary cause of hypertension in these group of patients. They are not usually benign essential hypertension. And hypertensive urgency is usually the systolic blood pressure more than 80, diastolic more than 20, and treatment is many of these patients are non-compliant with antihypertensive therapy and do not have clinical or laboratory evidence of new or worsening target organ damage, and reinstitution of or intensification of antihypertensive drug therapy and treat an anxiety as applicable, because many of them are anxious also. So that we commonly see in Mahamana, they be coming for chemotherapy, very, very anxious. We usually add a clonazepam or something like that to relieve their anxiety. And hypertensive emergencies are BP more than 180 with a target organ damage. What is the target organ damage? Papilledema, brain edema, acute pulmonary edema, all those things. And more than deteriorating renal function. Diastolic is usually more than 20, 120 and target organ damage. So difference between a hypertensive urgency and emergency is that emergency BP is mostly more than 180 by 120, but there's a target organ damage. And for these hypertensive emergency, you need to admit them in intensive care unit with a continuous monitoring of BP. You can give parenteral administration of appropriate drugs like labetalol, IV labetalol, IV nitroglycerin, and these IV diuretics. And new and progressive worsening of target organ damage has to be monitored in such patients. So this is like flow diagram for all patients of hypertensive crisis. Systolic blood pressure more than 180 or diastolic but diastolic blood pressure more than 120, target organ damage, new or progressive. If yes, it is hypertensive emergency, admit in ICU, consider aortic dissection, severe preeclampsia, pheochromocytoma, crisis. If yes, reduce systolic blood pressure to less than 140 in first hour and less than 120 in aortic dissection. If no, reduce BP for maximum of 25% over first hour, and then 160 to 100 or 110 over next 2 to 6 hours, and then normalize it next 24 to 48 hours. But if this target organ is not there, it means it is a hypertensive urgency. There is no need for admission. Markedly elevated BP, reinstitute intensify oral antihypertensive drug therapy, and arrange for a close follow-up in subsequent patients. The treatment choices, which is good for all of you, those who are sitting in the emergency department, that malignant hypertension with or without acute renal failure, and the timeline of target of BP reduction is severe, several hours, and first line treatment or IV labetalol, which is commonly available with you. Nitroprusside is another alternative drug therapy. IV nicardipine is not available with us. Hypertensive encephalopathy, we need to immediately reduce the mean arterial pressure by 25%. IV labetalol is still the drug of choice, and IV nitroglycerin can have. Acute coronary syndrome, immediately reduce the blood pressure systolic to less than 140, and nitroglycerin is a drug of choice. Labetalol we can give to some of them, but those who are having acute pulmonary edema, IV labetalol or IV metoprolol will worsen the heart failure. So there we have to avoid it. Acute cardiogenic pulmonary edema, IV nitroglycerin, IV diuretic, nitroprusside. Sometimes because nitroprusside is a very difficult issue. Aortic dissection reduce the blood pressure up to less than 120. And esmolol, nitroprusside, nitroglycerin, IV labetalol, they're the common drugs. Eclampsia and severe preeclampsia, we have to reduce the systolic blood pressure less than 160 and diastolic less than 105. IV labetalol or nicardipine or magnesium sulfate is a drug of choice, and consider delivery for such patients as fast as possible. And for regarding hypertensive urgency, accurate BP measurement is important. Diagnose if it is more than 180 by 120. Presence or history of CVD or end organ damage. If it is end organ damage, definitely hypertensive emergency. If no emergency, identify risk of hospitalization, death in 1 year. Reduce the risk by good adherence, standard healthcare provided, and ask them to have. Do you have ever forgotten to take your high blood pressure medication? Do you ever miss to take high blood pressure pills when you feel sick? Do you ever miss taking high blood pressure when you feel better? These are the important things have to be taken care of with this hypertensive urgency patient. So these are the European Hypertension Society guidelines, your ESC Council hypertension solution documents for management of hypertensive emergencies. Make hypertensive urgencies not a separate entity but a diagnosis of exclusion. There is no evidence that treatment is patient with acute who lack acute hypertension damage is different from patients with asymptomatic uncontrolled hypertension. So the hypertensive crisis that was meant to discriminate between hypertensive urgency and emergency now becomes an obsolete terminology, and we have to use it. Device-based hypertreatments are there. I will discuss these issues in resistant hypertension because newer devices are coming for hypertension management. So thank you all for such a long listening in Sunday evening, for all your patience and thirst of learning for hypertension management, which is a common clinical problem in our clinical practice. If there is any question, any comment, it is open for you all can.
Thank you, sir. Any questions from any of the residents?
They have nothing, none of them have understood anything or they have understood everything.
Prashant, would you like to share any of your experience with sir in terms of management of hypertension? You must have seen a large number of cases yeah.
By now I have shared many of these.
Hello.
Yes, Prashant, go ahead.
Good evening, sir. Sir, basically, I'm a fresher, so I was not much aware of the treatment protocols. Although I've read in pharmacology the name of the drugs, the class of the drug, but here while practicing, I'm able to prescribe the drugs based on seeing how sir assesses the each patient and how he's prescribing drugs. Mainly, it's different compared to a general physician practicing outside. Here, we have to consider the thing like if the patient is planned for a surgery. So the first thing we have to look into the other comorbidities, like there is the diabetes or not, smoking, the habits, obese patients. So considering these, we prescribe like amlodipine, the first, and along with that metoprolol. So these are the two drugs currently we are using. And then if the BP is controlled, then we continue the same drugs, or if it is not controlled, we go on to add other alternatives like ACE inhibitors.
Okay. And also, if any of the other residents wish to get rotation with sir, then we can consider it when we have sufficient number of residents in medical oncology. So that is also feasible, and we can discuss with sir if any of the residents are interested in having rotation in general medicine. And also, we are working hard to start cardio-oncology unit and also tobacco de-addiction unit. Sir will be the official in charge of these units. We are trying to work it up and establish the same as soon in next coming months. So, Ajay, I think sir was disconnected. So, sir, I was just yes, sir. So, sir, I was just talking about the opportunities with other residents as well, that those who are interested to get rotation in the general medicine are also welcome. We can consider them rotating in your unit so that they also can benefit from your guidance and direction, if feasible and if
sure, they
proper.
are most welcome. They are most welcome. You
Yes,
know,
sir.
just keeping on for some hours, you know, may not be for the whole time, because I'm there
Correct,
in the morning hours. So if they can have, if they wish to come, you know, every week or so, they can rotate themselves, or you can have one day, Monday, someone can come to me with Prashant, Tuesday, someone can again, you know, this way 7-8 people are there. They will have a more exposure of looking into the things into like diabetes, hypertension, hypothyroidism, anemia. All these common clinical problems are many times seen in the OPD, and having an OPD experience is quite a good amount of experience, if you, because admitted patient you can see, you know, in a limited options only, but OPD patient every day there are 15-20 patients, and if more people are there to see patient, we can increase the load of seeing patients every day.
correct, sir.
Only
Correct, sir.
Prashant
So,
is looking into.
yes, sir. We'll be working upon it, and we can give 3 or 5 days or a week rotation to the residents, so that you can get one extra hand as well, and also our all residents get exposure for working with you, because it is a very essential experience to have training in at least management of diabetes and hypertension, besides seeing the ECG and echo findings and prescribing drugs. Because we have seen, sir, already that we have a significant number of patients who have CHF. At least the decline in the ejection fraction is common. We thought that it is not so common, but now when we are seeing carefully, we see that we see at least one patient having low ejection fraction every day. So that means that, yes, sir. So as we have discussed, we'll be trying to start cardio-oncology clinic and tobacco de-addiction clinic under your guidance shortly. In the meanwhile, we'll train more and more residents to be acquainted with our protocols.
Right, and we can have, you know, last time around a few weeks back, I had a few of sessions with anesthesia ICU resident as well. So I think this time they were not in a group of joining it. Probably they may get some information. Then they can also join, because most of them, they are senior residents, but they've already finished their MD or their rotation of their MD. So they don't have a clinical access of OPD exposure to these common clinical problems, but they can also share their own experiences of intensive care units. And similarly, they can share their experiences of their ICU settings, and our OPD residents and OPD registrars can share their. Because what I will suggest to all of you, those who are here in this forum, what Akhil and me are trying to make a habit for all of you, and what I realized over my last 20 years, 30 years of clinical practice, that what you read in your textbook will never help you. What you see and what you read after seeing the patient will help you more, and more and more clinical experience will grow up, will make you a better physician, a better doctor one day. Because only just reading theoretically, you all must be much more better than me, particularly at this moment when you are appearing in your PG entrance exam, in telling me what are the investigations you can prescribe for secondary hypertension. But having an index of suspicion for secondary hypertension in a patient is more important. Measuring a blood pressure, how to measure in a patient, how to do a clinical examination in a hypertensive patient, and make a habit of it. Make a habit of it that you should not miss anything. Though being an attentive physician, also you can miss sometime in a busy OPD. But whenever you are looking into the problems in a different perspective with a high index of suspicion, because of a high index of suspicion, those who are working in a medical area, my one of my professor used to call us, they have to work like a spy. They have to work like a James Bond. That if you have to keep your index of suspicion always very high for each and every problem, so you can diagnose them early and you can help them early.
Thank you, sir, again for the efforts and your expert comments. So if there are no further comments, we can end the session today.
Okay, thank you very much. Good night, everybody.
Good night, sir. Good night.